Good morning and welcome to our weekly grand rounds. It's my privilege this morning to introduce Dr. Sacco, who is an allergist, immunologist, and our clinical lead for inpatient immunology at Phoenix Children's Hospital. Dr. Sacco is an assistant professor at the Mayo Clinic College of Medicine and University of Arizona College of Medicine. He's a guest researcher at the National Institute of Allergy and Infectious Disease Lab of Allergic Diseases. He obtained his medical degree with distinction from the University of Malta, then pursued internal medicine residency at the Mayo Clinic in Florida. He then pursued a 3-year fellowship at the National Institute of Allergy and Infectious Diseases, where he joined the Laboratory of Clinical Immunology and Microbiology under the mentorship of immunologist Dr. Luigi Notarangelo. He currently serves as the Genetics and Molecular Biology Committee of the American Academy of Allergy, Asthma, and Immunology, and on the Committee of Inborn Errors of Immunity on the World Allergy Organization. He's also an ad hoc reviewer for multiple medical journals, including the Journal of American Medical Association and the British Medical Journal. His clinical and research interests include describing new immunological diseases and developing a molecular approach to managing rare diseases. And I must say that, there's only been a few physicians over my career that have really been game changers for our institution when they got here. And Dr. Sacco is definitely one of them. He brings in an expertise that nobody else around here has. And all of a sudden he's putting things on the differential diagnosis that we've never heard of on the wards, and really made a contribution to some of these patients. So it's my pleasure to ask him to share some of these cases here. And then he said he is going to have some time for question and answers at the end. And so residents and attendings, don't be the least bit embarrassed to ask some basic questions because this is kind of the new frontier of pediatric medicine. And it's stuff that most of your attendings did not grow up knowing and therefore teaching to you. So, Dr. Sacco.
Thanks, Dr. Hartley. A very kind introduction. I'm really happy to be here, and it's been a very good journey the past 2 years. I would say I've learned a lot in terms. I felt it was an extended fellowship, so to speak, to learn on how the immune system can play out in space and time. I will just put that out there. Immunology can be pretty daunting. That's the reason why I got into it, because it was pretty daunting for me too. And please, if stuff feels that it's a bit over the top, you can stop me, and I'll try my best to simplify it as possible. This is the CME code for today.
Click on the big thing and then click on it.
Here we go. Excellent.
Okay, yeah. Just move it out of the way.
I do have a few disclosures in that I work with a few small pharmaceutical companies in regards to immune deficiency as an advisor and speaker. That work should not interject with what I'm presenting today, however. So if we take a step back as to what Dr. Hartley was alluding to, if we look back at 1983 up until 1995, there were around 50 genetic reasons for immune dysfunction, so to speak. Conditions like X-linked agammaglobulinemia, chronic granulomatous disease, disorders you are well aware of. But in 2003, there was that Human Genome Project, right? Genetics became cheaper, more accessible, and you can see this offshoot now. We have over 500 single gene disorders that we know affect the immune system. Now, classically, we would think immune deficiency was a susceptibility to severe and or recurrent infection. We know that that is not the case anymore. The immune system, I like to use an analogy. It's not to disrespect people's intelligence, but analogy is kind of the storytelling has been in human history. And the immune system I like to compare to a martial artist, extremely strong, but knows, part of the discipline of martial arts is to know how to contain yourself in public and not cause a scene every time, right? So the immune system is extremely powerful, can fight off infection, can fight off non-self, so infection and cancer, but at times can go rogue. And going rogue means the immune system mounts a lot of inflammation. Inflammation can be either just purely what we call intrinsic, meaning the body is just throwing inflammation left, right, and center, but it could also be a targeted approach, meaning using immune cells like T cells and B cells producing antibodies to attack itself, right? And all those are forms of immune dysregulation. So in summary, a inborn error of immunity could be a susceptibility to severe and or recurrent infection, which is what we know of. The second is significant autoimmunity, meaning the adaptive immune system attacking its self, or significant inflammation. Sometimes we call that autoinflammation, which is a term that came about around 2014. But also, let's not forget hypersensitivity. And hypersensitivity means the immune system overreacting to stuff that's outside the body, be it peanut allergy or pollen, right? That if it's significant allergy, sometimes there's genetic reasons for that. And patients may have a combination of all this. So how do we approach immune deficiency? And I usually tell residents, I dumb it down to 5 things, right? We can get stuck in what I call diagnostic paralysis in immunology. We can just get stuck on Mount Olympus, and just placate from that podium. But in actual fact, how are we going to help the patient? And I will say, are we going to start preventative prophylactic antimicrobials, antivirals, antifungals, and antibiotics? Do we start immunoglobulin replacement, whether IV or subcutaneous? Is the patient a candidate for stem cell transplantation? And here we're pretty blessed and lucky. We have the immunohematology clinic that led by Dr. Holly Miller, who does a lot of transplant. Around a quarter of the transplants, bone marrow transplantation happened at Phoenix Children's last year was for immune deficiency. And then genetics comes into play because we can discuss prognosis. Sometimes if we find a specific gene, we can screen for specific cancers. So I'm sure you've heard from your step 1 ADA SCID, right? ADA SCID can present with a specific tumor called dermatofibrosarcoma protuberans. And that's where we work closely with dermatology for these specific types of tumors. MACT1 deficiency can present with a tumor recently described in 2019, I think, Merkel cell carcinoma. And the main cancer in immune deficiency, however, is lymphoma. So genetics can be really helpful, especially there are around 30, 40 genes that have a high risk for developing lymphoma. Now, today I'm going to talk about, what interests a lot of people, which is, throwing potions around, which I call targeted immunomodulation. I call this beyond the frontier because there's not much data. A lot of this clinical trials cannot answer these questions, right? It's really using clinical acumen and diagnostic tests in short space and time to describe the mechanistic medicine underlying the pathophysiology. And sometimes, these patients can get really sick, as we're going to discuss. And I'm going to show 2 cases today that were formerly thought to have a type of immune deficiency, but we're slowly teasing out that there's much more to the surface of that immune deficiency. So I'm going to talk about common variable immune deficiency, which is an immune deficiency I think most of you know about. It's called common because it affects around 1 in 25,000 people. In certain countries, for example, let me just say Kuwait, it's around 1 in 10,000 people. It is a clinical definition. So there is no gene that specifically defines CVID. It refers to having low immunoglobulin, low IgG, what we call less than 2 standard deviations, meaning less than the lower limit of normal, with either a low IgA and or a low IgM. And of course, it's not about just having a low number, it's about function, right? If you look at armies historically, if the immune system is an army, before we had X number of horses, now we don't use horses, we use robots, right? And robots can achieve the same function with less numbers. So most important function of the immune system, again, is to prevent infection. The best test to assess whether the immune system is working or not is to see if there has been a response to vaccines, specifically protein-based vaccines like tetanus and polysaccharide-based vaccines such as Streptococcus, the 23-valent Streptococcus vaccine. And of course, never forget ruling out secondary causes, right? You could have an infant who has an infection that affects T cells. There could be also underlying malignancy, or using immunomodulation, right? So the kids who've received chemotherapy or other immunosuppressants can present with this phenotype. Now, we used to think, oh my, the big problem with immune deficiency is infection. Well, that didn't really transpire to be true. The biggest cohort of CVID is up in New York, Mount Sinai, and they published now over 10 years ago their biggest cohort of over 400 patients with CVID and showed what factors affect survival. And what they found was that these patients had quite a bit of cancers, not adult cancers. Today we're just going to go back a bit and forth. Pediatrics, a bit adolescents and young adults. But also granulomatous inflammation, granulomatous disease, lungs predominantly, as well as liver. And they also had significant autoimmune conditions, the most common one being immune thrombocytopenia and autoimmune hemolytic anemia, as well as significant GI disease that may have been labeled as ulcerative colitis, Crohn's disease, nodular lymph node hyperplasia. But inflammatory bowel disease, as we'll talk about, is a big component of common variable immune deficiency. Now, this was one of, I won't say my favorite slides, but I think it's a very important slide to take away that hit me when I was in training, in that if you look at survival, a CVID patient versus an age-adjusted, healthy, so be it healthy patient, there's decreased survival. As you can see here, we have CVID males assigned at birth and CVID females assigned at birth. Males, of course, have a lower life expectancy than females, but there is a lower survival. But when you look at the CVID patients that did not have non-infectious complications versus those who had non-infectious complications, meaning autoimmunity, cancers, and granulomatous inflammations, you can see that survival drops significantly, right? And so if you had CVID with infection, just CVID with infections, then your survival is around 95%, even at 40 years of diagnosis. We've learned that if you give high dose IVIG, or even sub-Q immunoglobulin, if your immunoglobulin level is above 1,000, now for kids it may be a bit lower, age adjusted, but we're looking maybe at the lower limit, somewhere around 600, starting around age 5 and creeping up, around by age 12, you want to be at over 1,000. That can slow the progression of certain inflammatory diseases, such as bronchiectasis. I like to call bronchiectasis as an ongoing inflammatory disease, not just a sequelae of recurrent infection, which we don't have time to go into today. But that brings a good point, and that's, we have to start looking at non-infectious complications in immune deficiency. Now, CVID, like other diseases, we've starting to chip away at it with genetics. And we now have identified, I would say even a third of CVID now has a genetic basis for it. And we'll talk about why this is important. So this was a study done actually in Europe, and they identified, I'm sure, I throw these genes around because now your residents get to know these patients, right? These are all patients we have here at Phoenix Children's. We have patients with NF-kappa B1 deficiency. We have a few patients with CTLA4 haploinsufficiency, right? Patients with PI3K-R1 deficiency, and PI3K-CD, for example. So these are conditions where the genes affect signaling in T cells and B cells. So it's really a loss in communication. And I like to compare this to, when we talk about this black hole of T cell and B cell signaling, it's like to me, it's like the New York subway, because I find it just as confusing. So it's really, you're trying to, one line is down, then of course some other lines get overloaded, right? And that's kind of what inflammation is like. Yep. And why is this important? It's because it may have implications for targeted treatments. And let me just use an example here. So CTLA-4 haploinsufficiency. CTLA-4 is the one of the brakes of the immune system. The immune system has 20 times more brakes than accelerators. It's not a normal, vehicle. You have a lot of brakes, and you really don't want to manipulate too much on the accelerator side, because historically we've seen there have been significant side effects with drugs that manipulate the accelerator. CTLA-4 is the brake, right? For those of you who want to do oncology, you've seen this CTLA-4, right? There's CTLA-4 inhibitors in cancer, whereby that stimulates the immune system to go and attack the cancer. In this case, there's low CTLA-4 expression, right? And what happens is that the patients can have a lot of autoimmune conditions. Autoimmunity, like ITP, low cytopenias. We recently had a patient who presented with cytopenias in the PICU, right? And so abacusep is a medication. It's a CTLA-4 Ig humanized that can bind to that CTLA-4 and keep it on the cell surface longer. In keeping that on the cell surface longer, it can break the immune system better. Yep, does that make sense? So it's a targeted treatment. We don't have data, we don't have 400 patients to go and look at outcomes such as, does it improve survival? But we do know by case series that it can improve morbidity. There's this other condition, APDS type 1 or type 2 PI3K-CD or R1. Those are the genes whereby there's an inhibitor of that protein. There's an overactivation of the immune system. And so we try to inhibit that with this drug called leniolisib. And there's other conditions like STAT1 or STAT3, gain of function, whereby if you have high STAT3, you have a lot of inflammation, and the immune system is going into overdrive, and you use a JAK inhibitor. You've probably heard of the JAK-STAT pathway, the JAK receptors, to try and slow down that overdrive. So it's really immune deficiency. We're talking about a subtype here where there's inflammation, the system is in overdrive. And if the system is in overdrive, it's then, getting lazy, not fighting off the infection that it should be, right? So that is, we're preaching really to the choir here. We now know that we really should be getting genetic testing from the get-go, especially here where we have underserved populations that have not really been well studied. And we've already described a few genetic susceptibilities of, let's say, valley fever, right? We have described CTPS1 deficiency and XLB1 as being novel presentations of significant valley fever, right? So crazy slide. This is one of how the classification, those 500 genetic diagnoses is how they're presented every 2 years, right? And so this is how, when you look at all this, you're like, okay, how do I approach this? But these are disorders that were formerly thought to be CVID, right? I am going to focus on this space, CVID with no genetic defect specified. These tend to be the hardest to treat if you have non-infectious complications. And so I'm going to use one case. There are some residents who've taken care of this patient, how we ended up, working through this patient. So this was a patient who had a diagnosis of CVID with Crohn's disease. I'll put that in quotes. I don't want to cause a stir here, but the difficulty with terminology in these diseases is that you can't just put a label. We have pathologists in this room too. Sometimes pathology doesn't look doesn't look like a duck and quack like a duck, right? And so this was a 10-year-old female presented to the ED, 2-week history of severe abdominal pain. This was her past medical history, CVID. There was an outside allergist immunologist who had started immunoglobulin replacement. She also had failure to thrive, short stature, thought to be secondary to the failure to thrive. And she had refractory Crohn's. She had already tried 2 biologics, adalimumab, which blocks TNF alpha, and ustekinumab, which blocks which blocks P40. P40 is a protein that is shared by 2 cytokines, IL-12 and IL-23. Right, and IL-12 is important to produce interferon gamma. IL-23 is needed to produce what we call antifungal immunity. If you have too much of that, you can get psoriasis or Crohn's disease, right? So she had failed these 2 mechanisms, right? So now you get the analogy of the subway. I'm thinking, okay, there was these 2 lines, blocking them didn't really work. What should we think of? And she was recently admitted for elective laparoscopic ileocectomy. I'm going to shorten this because otherwise we wouldn't get through the whole case. But overall, she had refractory Crohn's disease. And during that admission, she had abscess, stricture formation, was placed on 3 weeks of antibiotics. So she comes in with abdominal pain. She ED radiology read this as high-grade small bowel obstruction. And then I get a phone call from the GI doctor and surgery, who been great colleagues in this case, whereby they took her to the OR. She had severely inflamed variable bowel, a lot of adhesions. The surgeon said, you know, I've never seen this type of bowel. Really looked so angry. Had silo placement with endoleostomy and had abdominal closure. Then pathology was pretty nasty looking, had necrotizing granulomas with abscesses, and there was hemorrhagic ischemia and adhesions in the ileum. And this is great, you know. I mean, I love it when residents are on the teams, because they start workups, you know, and they start differentials, and they had already gotten these labs. You know, they got a procalcitonin, a CRP was elevated, ESR was not, the IgG was 800, which is a very good number while on IVIG. Of course, you had bowel obstruction, could not obtain a calprotectin to assess inflammatory status. And the question was, we'd like to start immunomodulation. And sometimes it's good to just take a step back, because I was also taken aback by, you know, what I saw with these pictures. And so sometimes it's just good to dumb it down, look at the bird's eye view. Is this infection or inflammation, right? And then if it's inflammation, where should we go next? We've already failed 2 other medications, and she was already on Zosyn. She was in the ICU, PICU sedated, intubated on pressors. And you don't want to poke the bear, so to speak, if you don't know who the bear is. The unknown unknowns were really showing up here, for lack of a better term. So I was with the fellows and the residents, and we brainstormed, okay, what would we throw around? You know, what other medications do we have? If it is inflammation, and if there is concomitant infection, let's not forget, for example, in SARS-CoV-2, kids presented with overwhelming inflammation rather than death from infection, right, with MIS-C. So sometimes a bug can trigger overwhelming inflammatory cascade, and you really want to suppress that inflammation while at the same time treating infection, right? And this is a double-edged sword. We thought of vedolizumab. What does that do? It blocks trafficking of T cells. We thought of sirolimus, which blocks T cell signaling, mTOR, similar, it's close to that P10 delta. Now, sirolimus is a bit difficult because the levels fluctuate, take long to get to a certain level. We thought of a JAK inhibitor or JAK inhibitors, because there's 4 JAK receptors, JAK1, JAK2, JAK3, and TYK2, and we're trying to figure out where do we go if we do that. And then, you know, one of the fellows said, why not try IVIG? And because high-dose IVIG, as you know, in neurology and in ITP, we do use that as high dose for anti-inflammatory status. We think we know how it works. We're not really sure how it works, but it seems to work. And so we actually proceeded with IVIG because we felt if there was an infection, things looked very scary. There were parts of the bowel that were oozing. At least, you know, we're kind of hitting both arms of both infection and inflammation. We got some further studies, and I'll walk you through why we got them. So rubella, both wild type and vaccine strain, in certain immune deficiencies, can lead to granulomatous inflammation, granulomas in the bowel, in the lung, in the liver, and even in the brain. And that was negative. We also looked at soluble IL-2 receptor alpha. You know this more in the HLH world as CD25, right? Soluble CD25 was elevated. We sent out these labs to outside labs, IL-18, CXCL9. IL-18 is part of the inflammasome. It's elevated. IL-18 is a half sibling with IL-1 beta. Yeah. CXCL9 was elevated. CXCL9 is a downstream marker of interferon gamma. So I know that then IL-12 signaling is going high. If I see CXCL9, again, from pathways, we know that interferon gamma is up, IL-12 is up. IL-18 is up, the inflammasome is up, right? And someone has recommended blocking CD25, and I said, definitely not, right? That's like taking out a military general, so to speak. CD25 is a key receptor for T cell activation, and once you do that, you take away out all the T cells. Let's not forget, it's not about T cell number, it's also T cell diversity. When I have residents with me, I ask them, what is more abundant? An infant's diverse, unique T cells, or the number of grains of sand on planet Earth? like an infant at 10 months. And they look at me and they, say, oh, maybe the infant or the grains of sand, but it's really, there's more diverse T cells at age 1 than there are grains of sand on planet Earth, which is mind-boggling to comprehend. But all of us, for example, just to say SARS-CoV-2, all of us preceded the pandemic. We had SARS-CoV-2 specific T cells 5, 10, 15 years, 20 years before a pandemic occurred, right? And so we already have that diversity. When you use something like CD25, I'm saying this because it gets used a lot sometimes in acute situations, you're wiping out that diversity. And so, as you know, probably in HIV world, and a key question the infectious disease doctors ask is, what was the CD4 nadir? Meaning, how low did it go? Because if your CD4 T cells went down to, let's say, 10, then you've lost a lot of diversity. Even if you have 2 patients at CD4 T cells at 800, but one went down to 10 and the other went down to 600, the one who went down to 10, even though they reconstituted, did not reconstitute that diversity. So they're still more susceptible to infection, just to make that point. Anyway, that was a bit of an aside. I'm trying to put in some clinical pearls as we go through. Lymphocyte activation markers in peripheral blood were a bit elevated. That's already CD25. This specifically looked at the T cell, right? We're not just looking at how much of CD25 was swimming in serum, which was elevated here. We also saw that CD25 was on T cells. So it's probably doing something, right? Let's not forget, this is circumstantial evidence, like going to a murder scene and finding a knife with blood. You still cannot, accuse anybody, but you have circumstantial evidence, right? Now, we just took a step back. So what do we think is going on? And so this paper had just come out around that time. And I think it highlighted what we already thought we knew, and we kind of knew this, but it showed it to us in a research setting, meaning that in CVID, in common variable immunodeficiency, this theme will keep coming up. There is hyperactivation of the immune system, both the innate immune system and the adaptive immune system. And that can lead to system burnout, which is why you get infection, because the system is not working well. And so I'm not going to really delve too much into this study, but in the study, what they found was that patients who did not have complications, the non-infectious complications, did not have the inflammation. So the patients who had non-infectious complications, the inflammatory bowel disease type stuff, granulomatous inflammation, those had high CXCL9, high TNF-alpha, CXCL10. So they had high inflammatory markers as well. And so we thought, if there's anything that is non-infectious, that is probably what's going on. And we need to find a way how to suppress the T cells without causing harm. We did that in med school. First, do no harm. It's very easy to cause harm when you play with these potions, right? And so I'm thinking, I think we had a question. We were thinking now, okay, we're on high dose IVIG. We need to plan the next step because the immune system will catch up with us eventually. And so JAK inhibitors came up, and the reason they came up and we brought them up was because we do know that JAK inhibitors are like in a way, they're like the people on subways who work, to shuttle folks around during rush hour, for the same analogy, right? Sometimes you're trying to modulate a system, and there are, as I said, JAK1, JAK2, JAK3, and TYK2 receptors, and JAK inhibitors may not block the same type of receptor with the same efficacy, right? So you have drugs like upadacitinib and abrocitinib that are specifically JAK1 inhibitors, and those really work nicely in eczema and skin inflammation, because JAK1 really drives skin inflammation. But I was really interested in this in JAK1, JAK3, because as you can see, IL-2 was up. How do I know that IL-2 was up? Because CD25 was elevated. The IL-2 receptor alpha was up, right? So I know that was up. We also knew that our T cells were activated. And also there's a drug called tofacitinib that blocks both JAK1 and JAK3 that is approved, FDA approved for ulcerative colitis, right? So we know that it does something in GI inflammation. The other reason I do not like to block JAK2 is because interferon gamma, which is really needed to fight off infections like mycobacteria, valley fever, right, is the co-receptor of, it works with JAK1, and so interferon gamma signals to JAK1 and JAK2. And so I in my mind, I try to rescue interferon gamma, even if it's doing something, by not blocking JAK2 directly, if that makes sense, right? Drugs like ruxolitinib block JAK1 and JAK2. Yep. So we looked at this, this group here that, all these cytokines are really elevated. Looks like there may be JAK1, JAK2 inhibition. Anyway, lo and behold, we still, sometimes the good answer is to still watch and wait. We continued high dose IVIG for 10 days, which is scary. It is, I'll just put that out there. I don't like to go beyond 5 days. This was a very sick patient. Liver enzymes then shoot up. There's very high risk of coagulopathy with high dose IVIG. And, we're working with the team. But, it was a bit of what we call a Hail Mary, I guess. But her CRP did downtrend, went out to abdominal washout and closure, and the gut looked much cleaner. Then she was extubated. I just want to point out one thing, that she already had genetic testing, and there was this variant that showed up, IGF-1 receptor variant. Now, a variant means that it's present in less than 1% of the population. Doesn't mean that it's causing disease. And the thought was, oh, if that was low, that's why she was, that could have been a reason for her short stature. Now, what we knew was that STAT5 signals downstream of that. So I really wanted to prove that if that is really causing anything, STAT5 would be low. So we got STAT5, it's a bit of an esoteric test, and on unstimulated CD4 T cells, and also upon IL-2 stimulation. IL-2 is your gasoline for the immune system. And STAT5 was pretty activated, very activated. So that told me that getting a JAK inhibitor, would downregulate STAT5. So she was on, as we said, ustekinumab, switched to tofacitinib off-label, 5 milligrams BID. I will have to shout out to Dr. Pasternak here for spending maybe quite a few hours to get this prior auth done. And that was done on day 21. And in 6 months, she's gained weight. She's stayed out of the hospital. She's gained some few centimeters too. Also, I think she's back playing soccer, reports significantly improved energy levels, and hasn't missed a day of school. So somehow, using this, peripheral circumstantial evidence was a very nice story, and definitely something that we will have to report. I will just mention, we have used JAK inhibitors in other conditions. I've alluded to this previously, STAT1, STAT3, gain of function, these autoinflammatory syndromes, one is called CANDLE. We went for JAK1, JAK3 inhibition in this realm because of the cytokines that were elevated and the prior approval in bowel inflammation. So I hope that wasn't, I hope there was some tension to that. That was part of the, but that's part one. And I'd like to now discuss a second case with a different organ system that was affected. I would say an organ system that freaks me out a bit more. Typically, the immune system is located at the main sites where intruders can come in. So the skin, the gut, and the lungs, which is why you get most infections at that site, where you get most allergies and autoimmunity at that site, right? Makes sense. You have most immune system. 70% of our immune system resides in the gut. Now, 20 years ago, we used to think, oh, the CNS, the brain, is an immune privilege site. I'm sure you have heard of this term, right? Immune privilege. We know that that's not the case. There's now studies that show activated monocytes from the gut track up to the brain, and they become microglia, and they can even alter signaling of neurons. I'll just leave it at that, so that I'm not going to start talking about leaky gut or whatnot, so you don't think I'm some there is some mechanistic basis for gut dysbiosis and neurologic manifestations, and that's I want that to lead us to our next patient, who showed up probably a fifth opinion, which is always a bit scary when someone travels around the country for an opinion. 12-year-old female with a history of CBID. And this is the difficulty with neuro. I'm not a neurologist. Maybe there's some neurologists on the call, but these were the complaints. The difficulty concentration, brain fog, diffuse body aches, aggression, involuntary tongue movements that began around age 8.5. She did have an outside EEG that did show multiple absent seizures daily, north of 15 per day. And she was seen in Texas in 2019, and she had a very, very good workup. She had what we call immunophenotyping. So we looked at We looked at the B cells. Are the B cells misbehaving? We tend to look at B cells in autoimmune conditions. Let's say lupus is the classical example. We look, are there memory B cells? You want your B cells to produce memory. In CVID, you typically have low B cell memory. And sometimes you have these, the B cells that go rogue, what we call autoreactive B cells. And if you see a lot of that CD28, it means that the immune system is pumping out antibodies. We don't know if they're good antibodies or bad antibodies. We know that the system is in overdrive, right? She also had low NK cells. These NK cells are needed to fight off viruses and cancer. Her IgG, that's a very good number. She was an immunoglobulin replacement. IgM and IgA, I didn't highlight them in colors. They were within age-adjusted reference range. And then there was this test. We talked about diversity earlier. You can check for diversity by using this test called V-beta spectrotyping, right? And why do we do that? Sometimes, again, if you have certain immune cells that we say develop clones, both B cells and T cells can do this, you can develop what we call lymphoproliferation or uncontrolled inflammation. They also check EBV and CMV PCR in blood, and we can talk a bit about why that is important as well in combined immune deficiency, and that was negative. And they also got an exome sequence. I now do not use, I'm not a geneticist, but I do not use the term whole exome sequencing. The reason being is because nothing is absolute in medicine. You cannot get the whole exome sometimes, but also the exome is, let's not forget, 1 to 2% of our genome, right? And so there's a lot of areas, the splice regions that may not be covered. But they found this variant called TASI. Now, for some of you who've rotated with us in clinic, TASI is this variant that tends to show up in CVID. TASI shows up in a lot of other autoimmune conditions, lupus, lupus nephritis. It's not this, pure variant that we know. We don't even know if it's causative for CVID. Yep. And so then the issue is, in 2020, she had significant behavioral regression. 70% of the time she was nonverbal. Of course, this was at a time when, schooling went online. She was having some difficulty, but she did get a CSF that showed increased protein and lymphocytic clear negative for oligoclonal bands. And, they looked at, the common autoimmune encephalitis autoantibodies, the AMPA, the voltage gated, whatnot, and that was all negative. And this is always a difficult realm, right? In autoimmune disease, especially in rare disease, sometimes there may be autoantibodies that we haven't described yet, and we may have to do proteomics. That's why it's super important to have a biobank at a pediatric hospital, because you are always dealing with rare disease, and it's good, okay, let's take a bit of CSF, and maybe when the technology is around, or we have the funding, with $2,000 per around that, you can figure out if there's not antibody, right? So this is really important to have that infrastructure. Yep. And so she was starting on rituximab, blocking CD20 positive B cells, right, every 2 weeks, and she did have some improvement. So we're thinking she had increased plasmablasts, right, CD28 positive. Starting on rituximab, we're seeing some improvements, but then she regressed. And sometimes this is the difficulty. When you get a case like this, you have to prevent, you go through, is this Munchausen, how much of this is real, how much is this is overdoing stuff, right? It's always hard when you have 45 minutes to try and tease that out. She was then starting on mycophenolate, right, to block T cells, but also in extent B cell signaling 3 months later. And she had persistent B cell lymphocytosis, meaning her B cells, usually rituximab shuts down your B cells to 0, right? The B cells persisted. Now, she was still having these absence type seizures. Again, she wasn't seeing neurology here in house, which also makes things more difficult, right? But these were her seizure type meds, what the neurology was prescribing. She was then on top of rituximab and mycophenolate, started on tocilizumab, which blocks IL-6. How do you know that you have high IL-6 in the body? You measure a CRP if you have a healthy liver, right? Because IL-6 goes to the liver, say, hey, produce CRP, right? So that's a cheap way to figure that out. And but because her CRP was more than 25, initially these psychotic episodes, head banging, decreased, but then increased after 2 weeks. She was then on top of that started on a JAK1, JAK2 inhibitor, baricitinib, but this was really bad after a few weeks, and that was discontinued. And Mom's request was a pretty tall order, I felt, that we were going to use a rational approach to immunomodulation once she was on these meds, high-dose IVIG, rituximab, mycophenolate, and toci. And again, when you take this approach, I think the overarching theme today is to first do no harm. First, do no harm. What I usually do when patients are on all these meds, I do a virus screen for what I call the big four, EBV, CMV, and then those are the big two, and then to a lesser extent, JC virus and BK virus in PCR, because that has implications in management. Thankfully, the first three were negative. BK was there was a very few low copies. This was a bit of her immune evaluation. Let's not go too much into that. She was a bit neutropenic. Her IgG was elevated because she was on a pretty high dose of IVIG, as what we give in autoimmune encephalitis. No B cells, so she did not have B cell lymphocytosis on Rituxan. She had low memory cells, T cells, and high naive T cells. NK cells were on the low end. Valley fever, serology antigen negative. All the peripheral cytokines were not elevated. And I think this is also an important point. You may have inflammation that is organ specific that you not pick up in peripheral blood, right? So I looked at, when you get a positive BK PCR, you have to check, do some imaging, right? It wasn't clear cut for encephalitis, but when I see this positive, I had to wean off mycophenolate. That's my main concern. Wean her off to 250 BID, did not lead to recrudescence. Actually, she did stabilize a bit. There were less psychotic episodes, and repeat BK PCR was negative in 3 months. I then obtained records that she also had targeted testing outside her exome, which again, probably the exome should have picked this up. My point being is the exome, if you're not looking for certain variants, they may not be described. So she had this MEFE variant. Some of you may have heard of familial measuring in fever, right? FMF usually presents not in this way: fever, joint pains, rashes, sometimes abdominal pain, pretty clockwork symptoms lasting 2 to 3 days. She did not have that, but sometimes you can have inflammation with FMF. And this is the TASI variant. We call it TASI, the TNF-RSF13B variant. Back to this crazy table. So this is what we're dealing with here, right? So the antibody deficiencies with the TASI variant, right? And so it says here that there's variable expression and penetrance for these variants, and it's a dominant type condition. This was the worst phenotype, I would say, or at least the most medicated patient. I'm also use the word most medicated patient with TASI. And so then the questions are, right? We looked at infection. We did a bit of a screen. Cultures were negative, etc. Looks like we stabilized a bit, but not that well. Could the MEFE variant play a role in the disease? Could there be inflammation, right? And how can we answer that question? Well, the cheapest way is to do trial of empiric colchicine. But also, let's not forget, we're talking about the blood-brain barrier here. We may need a drug that, really crosses the blood-brain barrier, and she did not really improve. Now, we did not see any changes in the serum. How about if we now stimulate T cells, right? And so I worked with, this is thanks to Roshni Abraham at Nationwide Children's. This was a research work we did where she stimulated the patient's cells on, and looking at cytokine readouts. This is how they were stimulated. LPS and ultra-purified LPS, that's a bit different because it depends on how that goes. I'm not going to get into details. You stimulate either TLR2 or TLR4, so to speak, which is the innate immune receptors. And lo and behold, I'm not going to bother you with too many graphs today, but at baseline, her TNF-alpha was significantly elevated, and upon stimulation, IL-1 beta with the ultra-purified and ATP, LPS, IL-1 beta stim did shoot up. So IL-1 beta is a cytokine that we see in FMF. Now, what we did is we weaned mycophenolate, and we initiated anakinra, which blocks the IL-1 receptor. Now, there's other medications like canakinumab that are dosed every 4 weeks or so, right? And they're long-acting, but they block IL-1. Why did we go for a once-a-day medication versus canakinumab? Because there is, there is improved CNS penetration when this was studied. And so they were willing to just do an injection once a day to see if it worked. We also held rituximab. And why did we do that? Because we had never really assessed her B cells in a solid fashion off rituximab. I really wanted to see if we held rituximab, what would her B cells do? Mom always told me there was lymphocytic lymphocytosis. And so then, while on anakinra holding mycophenolate, we then reassessed her labs. I said the BK virus came back negative, and the B cell phenotyping didn't really show anything that was really wrong, but there were increased naive B cells, which is what we typically see after rituximab. But I got this lab, and I think nephrology get this quite a bit, rheumatology do this too. It's called a BAF level. There's a lot of literature in lupus about this level. What is BAF? BAF is a regulator of B cells that has, if elevated levels, can be implicated in autoimmunity in lupus. And there's a drug actually that can block BAF, and in patients who don't respond to rituximab in lupus, sometimes it can help with neurologic manifestations. So then we switched rituximab to belimumab. This is, again, prior auths. I'm not talking about the how today. I'm just talking about the overarching themes, right? Because the how is 90% of the work, I would say. We induced her and then followed every 4 weeks. And she said she did have some improvements. The improvement really happened after a few months, I would say. And mom used to notice these seizure frequencies. She said they went from 3 times a day around 10 times a day. The problem is, when you have a lot of autoantibodies, the efficacy in the system, right? We talked about tocilizumab, high-dose IVIG. You're competing with what we call the neonatal Fc receptor. Right? What does that do? That it leads to recycling of autoantibodies to improve their half-life, right? And so sometimes the half-life of these medications can be decreased. So I just wanted to show, I'm not going to spend too much time here, but I just wanted to say that BAF and TACI talk to each other. And so it could well be, in the literature, in immunology literature, we think that TACI is a decreased function of TACI is what leads to CVID. Based upon this case and some other cases, I would want to argue the counter to this, saying that increased TACI signaling may lead to autoreactivity and immune exhaustion, leading to decreased ability to fight off infection. But then what do we know about BAF and immune activation, specifically the innate immune system? And why am I talking about the innate immune system? Is because which is the most important immune cell, at least as we know of to 2023 in the CNS, is the microglia, right? And what's really cool is the microglia also conduct electricity, which we found out. Macrophages are in the AV node and they actually conduct electricity. There's a 2017 paper. Pretty mind-blowing, right? We used to think the immune system just fights off infection. It may even talk to neurons and conduct electricity. So we do know that BAF priming leads to pro-inflammation in the microglia, right? BAF stimulated monocytes, which, cousins of microglia, produce increased IL-6 in Sjogren's, and she was having increased IL-6. BAF from dendritic cells, monocytes, etc., is required for B cell maturation autoantibodies, which you kind of knew from B cells. So how do we combine both? Right now, BAF, we're looking at B cells, right? But BAF looks like it's doing something in the innate immune system, and I'd like to go to something that's not an autoantibody. Sorry, it's not a monoclonal antibody, because she was actually, I did not say this, she was actually only responding in the first 4 days of getting the infusion, and then she was going back to her what mom said was her baseline of not, being coherent. She was able to do her schoolwork those 4 days, and then she couldn't. So that's why I thought if I get to a small molecule, we can circumvent using a monoclonal antibody. So what do we do here? These are some nice websites we like to use, and I showed this to the residents. You can look at how proteins talk to each other based upon experimentation. There's a website that's free to use called String, and also UniProt that looks at proteins. And it tells you which pathways does a certain protein affect. And I wanted to talk about BTK. You've probably heard about BTK in XLA. BTK is the mutation in X-linked gamma-globulinemia, which I think is a B cell disorder. But let's not forget, BTK inhibitors were also used in COVID in the beginning because they were thought to decrease monocyte activation. So we also know that BTK talks to proteins such as MyD88. I mentioned TLR2, TLR4. MyD88 is downstream of that. That's an innate immune protein, right? So how about the BTK inhibitor? Now we're really going rogue here. So what we did, we stopped tocilizumab, and we did our very best to add ibrutinib. Again, needs a lot of monitoring. It's a hematologic drug, etc. This is really off-label, to target the monocyte microglia and B cell activation. Now, 2 months post-ibrutinib, she's the first time in 4 years that she's back in school, able to hold a conversation, and I talked to her, the first time I actually talked to her, which I asked, we need to repeat the EEG, definitely, currently on IVIG, and I'm planning to stop belimumab, We repeated the EEG, again, outside neurologist. She's going to plan to move in-house now. I think that's much better for coordination of care, but the seizure frequency with long-term decreased from 10 a day to 1 to 3 per day. So we're not there yet. I mean, we still need to understand the pathophysiology of this disease, but slowly we've gone from all those medications, identified infection, gone IVIG, anakinra, and ibrutinib. So I think it was a bit of a whirlwind, just a bit of a flavor of what we do. But I think functional testing definitely needs to be interpreted in context. You know, mechanistic phenotyping is important, but you also have to understand pathophysiology and that it's very organ specific. Sometimes the results may not show you what you want to see, and then there's always the why, right? Again, peripheral blood may not affect the organ. Watchful waiting, as in the first case, sometimes may be the correct answer. Do not do any harm. Sometimes high dosage IVIG, let's say 5 days, you know, please don't go beyond 5 days unless there's, you know, some people who are willing to take that responsibility. I would, that may be the correct treatment approach. And when you need to use something, go for the least harm again, shortest half-life, look at side effect profile. What I really want to point out is the support infrastructure. The drug monitoring for these drugs, nursing, when you use off-label medications, you will definitely get rejected. There will have to be peer-to-peers. There's hours involved. It is not, you know, it's not billable time, so to speak. I just really wanted to highlight, you know, my RN, Nicole, who has done countless hours. She's, you know, figured out, she's blazed the trail, so to speak. And, you know, and now we have new nurses joining us. We have Julianne, who's joined us too, and also Lindsay Lee has who have really worked. This is not easy because you're trying to explain to an insurance company that this is a drug that is needed, and that down the road the patient will have less admissions, hopefully. And as you can see, it's difficult even for us who do immunology. It's not an easy world. Sometimes you don't have literature. But also, you know, Dr. Bauer and Dr. Miller, who run the IHC clinic, and for the first case, Dr. Pasternak and Dr. McMahon, who, you know, we work very closely with each other, as well as Dr. Abraham at Nationwide, and Dr. Santoro, who does a lot of the autoimmune encephalitis in kids in California. I'm happy to take any questions.
When I glance at the Q&A, but usually the first one comes from somewhere. Raise your hand and.
There's a question.
Okay, okay, I'll ask the first one. You are an N of 1 right now in terms of what you do here. If you had your choice, if we wanted to give optimal care to all the kids that come here, how many copies of you would we need to make?
Yeah, yeah.
I mean, like, for example, if somebody has GI symptoms or infectious symptoms or some other symptoms, and we're not sure if it's in that person's specialty, we usually say, well, you know, why don't you come take a look at this patient, see if you have anything to offer. If we did that with you, you know, I think we would way overburden you. So you probably get the kids that, like, you know, it's kind of obvious that something, you know, something else may be going on, but what would be the ideal staff?
Yeah, that's a good question. I will just say, I mean, I was talking to my colleagues on the East Coast, and it was overwhelming how, I mean, we diagnosed 13 immune deficiencies in 2022, and I think, you know, 11 of them were referred for bone marrow transplantation. And again, I think it's a great team on the heme side, but yes, of course, you know, we're the only center in a big geographic region whereby, you know, help, I wouldn't just say in the immunology side, it's pathology, you know, that there's a lot of diagnostics that have to send out, the hematology side, but even on the hospitalist team, sometimes, you know, sometimes the biggest asset is time, right? You know, these patients who are hospitalized need a patient care conference. You know, I see, you know, we've done a lot with, you know, NEF, GI, you know, all these specialties. It's very hard to put everyone in a room, right? And these patients need that for our time because we all have our blind spots. There's always, for me, I think I really cherish having the time to talk. But, you know, we are actually we have two new folks who are joining us doing immunology, which is great. And as you're saying, sometimes you never know when things are needed. I will just say, I think around the time of the monsoon last year, we had 3 patients who presented with HLH inflammation, and they turned out to be within 3 weeks, XLP1, XLP2, and Griscelli type 2, which, you know, Cincinnati is the mecca for HLH. They've never seen that. It's a learning process, right? I think the more we look for, the more we find. And I think the flexibility of being able to be resourceful and being there is extremely helpful.
There's one in the Q&A if you want to just click on that up there, or you can read it yourself.
Dr. Wilson. Okay. So Dr. Wilson is one of our fellows. For those of you who haven't met Dr. Wilson, I think maybe another Dr. Wilson. Or do you have a general rule of thumb? So the question was, do you have a general rule of thumb with how long you would trial biologics immunomodulation in these cases before determining efficacy? And I think that's a very good question. The long and short of it, it depends on the half-lives of the drug, right? As well. Typically, you know, we say 5 half-lives, you get to steady state, and then you want to assess maybe 2 to 3 months, especially for neurologic symptoms. You want to have objective data. So 3 months is probably, it's a bit of a, you know, arbitrary cutoff. But also these drugs cost a lot. Pragmatically, insurance is not going to be switching a drug every 3 months either. You want to do at least 3 to 6 months, and you would stop a drug at 3 months if there's no efficacy and there's concerns of adverse effects. And that will be 3 months after achieving the steady state. Yeah, no, does it? So the question was, should genetic testing become more prevalent, and who should we refer to, you know, to get this done? I think, you know, I'm a believer of genetics. The issue is, you know, with anything you do, you will always have, genetics brings a lot of noise too, because you will get either pathogenic variants or benign, or else what you get in the in-betweens are the variants of uncertain significance. It's really important for the quality of the data that goes in the history, because now they actually use machine learning and AI techniques to pull out the history from these orders. So whenever you order, that's just one thing, like whenever even any specialties order these tests, make sure to get a chunk of the HPI, of course, without patient identifiers in that HPI section, because they pull out keywords. For example, if I said that this patient had Crohn's disease and CVID, they will be looking at around 40 variants from the 500 plus variants that they test for. And that's important because that decreases noise. Now, who to refer to? Immunology is growing a lot. We work very closely with genetics. You know, all of us unfortunately have a long wait times. That is the difficulty. Our group is getting more comfortable looking at genetics. We order a lot of genetics. So I order maybe around somewhere from 7 to 10 a week. In terms of targeted testing. Again, that takes, you know, half an hour pretty much of every test to go over manually to and decide what you're going to do with that. But I would rather err on the side of doing it, as we do. For example, we've picked up a lot of patients, you know, especially the underserved population, the non-English speaking population. We go in, we do the cheek swab, we test in the hospital, and we've diagnosed, you know, chronic granulomatous disease, patients who would otherwise have never shown up to clinic unless we diagnose on inpatient. So yes, I'm a believer of that.
Okay, I think we're at time. So again, thank you very much. And for anybody who missed the first part of the talk, we are trying to get most of our gun rounds up on the you can go to the link through the index website, but on the PCH website on the CME page, you can go to and most of the time you can get the recording later in the same day. Now, next week's will be our new craniofacial orthodontist, Dr. Preston. Look to see you there. Thank you.